Okay, so as I mentioned, we're going to talk a little bit about Merkel cell carcinoma and focus on initial diagnosis and management. Next slide, please. Oops, go back one, please. All right. So what is Merkel cell carcinoma? Well, it's a rare and aggressive cutaneous neuroendocrine tumor. By neuroendocrine, we mean originating from the neural cells in the skin, as opposed to, say, melanoma, which arises from the pigmented cells, or say the basal cell carcinomas, which arise from basal cells, or squamous cell carcinomas. It primarily affects sun-exposed skin. So we see this often in the head and neck region or in the hands and forearms of older individuals. And diagnosis has risen interestingly fivefold in the last 30 years. And from 2000 to 2013, Merkel cell carcinomas increased 95%. And the incidence is expected to rise even more, up to 2,500 cases per year, from up to about 2,500 cases per year to 3,250 cases per year by 2025. Next slide, please. And this is a schematic of the skin, just to kind of give you an idea of where these nerve cells that he's talking about. So the Merkel cells lie just beneath the epidermis and above the dermis. And you can see it there on the image, the expanded image on the left. Next slide, please. Risk factors for Merkel cell carcinoma, somewhat similar to other skin cancers. UV radiation exposure probably accounts for about 20% of all Merkel cell carcinomas. And interestingly, and more recently, a virus was called the Merkel cell polyoma virus, has been thought to be etiologic in about 80% of cases. Again, this tends to affect older individuals, Caucasian men being the primary highest risk group, and also affects our immunosuppressed patients. So our solid organ transplant recipients and patients with uncontrolled HIV. Now, interestingly, we've seen really a vast increase in all these cancers, especially in our organ transplant population, and they present us with some unique challenges. But I think the main point there is, if you are someone that's had an organ transplant and you are immunosuppressed, you should be in the hands of a good dermatologist and be seen regularly. And I know at our institution that's they not only get examined before they even get a transplant, they're examined quite frequently thereafter. Next slide, please. So in medicine, we always like mnemonics. It helps us remember all the different things that we have to remember. And so for Merkel cell carcinoma, it's AEIOU. This came from a paper in 2008 in the Archives of Dermatology. Basically, A is asymptomatic. So these are painless lesions, as opposed to some of those squamous cell carcinomas that you just heard about. They've rapidly enlarged. That's E for enlarging. They occur in immunosuppressed individuals. That's the I. Older patients greater than 50 is the O, and U seem to be associated with ultraviolet radiation. When one of these lesions is seen, someone like Dr. Chen or Dr. Alam will do a biopsy, either a shave biopsy or a punch biopsy. And what you see on H&E, which is our basic staining, are these bright blue sheets of cells. And on immunohistochemistry, this is kind of special stains that highlight certain cells for us. They're CK positive and TIF1 negative. So that's the CK positive cells, are those brown ones that you see, and this secures the diagnosis. Next slide, please. So now you've been diagnosed with Merkel cell carcinoma, and that's when you usually are referred to someone like me or Dr. Steppen. You're going to get a complete skin exam if that wasn't done already, and usually we'll do it anyways because we don't trust anyone but ourselves. We also do a thorough lymph node examination, and if there's any question about nodal disease, in other words, enlarged lymph nodes, then we'll usually follow that with cross-sectional imaging, such as a CT scan, an MRI or a PET CT. And interestingly, about 12% of patients with suspicious findings on their H&P, in other words, something unusual you pick up on physical exam or by talking to the patient, will have what we call occult or not previously unidentified metastatic disease. This is a patient who presented actually with a palpable inguinal lymph node as one of the earliest manifestations of Merkel cell carcinoma. So we don't necessarily image everyone right off the bat, but probably somewhere in your treatment course, you're going to get either a CT scan of the neck, chest, abdomen, pelvis, or a PET scan. Next slide, please. These are what we call our NCCN guidelines. And at Northwestern, we're very proud that we were a founding member, actually, of the NCCN, which was a small consortium of what we like to think of the best cancer centers across the world, across the country. But now has grown, and I think it's almost up to about 30 members, including places like MD Anderson, where I trained, Sloan Kettering, Duke, Stanford, Michigan, and, basically any place you would want to be treated has someone who comes to the table, and we have individual panels, and a number of the people on the call tonight serve on these panels. And this kind of walks you through what you need to do and how the workup will go. And so I often will, when patients come to my office, I'll have these printed out, and I just walk them through where we are, and I'm able to show them not only what they need to have done, but why they need to have it done. So you start over on the left with the suspicious lesion that's suspicious for skin cancer. There's a biopsy performed, typically again by the dermatologist, and then Merkel cell carcinoma is identified. So again, upon coming to my office, you'll get a complete skin and lymph node exam, and then we'll decide if we need other imaging studies. We'll typically talk about you in one of our multidisciplinary panels. And, one of the things that we do often overlook, but I think it's a really important point, is that for patients who are immunosuppressed, in other words, who are on immunosuppressant medications for a number of different reasons, but including for transplants, we try to minimize the amount of immunosuppression going into any curative treatment. For patients who are what we call clinically node negative or N0, next slide, there's two things that need to happen in the operating room. We take you to the operating room. One is kind of the easy thing. That's the one on the top. The excision with a 1 to 2 centimeter margin of normal skin. Sometimes Mohs can be done in these cases, but often the patients will see us because not only do you need to do that wide excision, and Dr. Steppen showed you some nice examples of wide excisions, you need to perform what's called a sentinel lymph node biopsy. And the sentinel lymph node biopsy is really what's going to drive not only prognosis, but treatment in these cases. So again, for the top part, you are typically excised with a 1 to 2 centimeter margin. If the margins are clear, we often will observe you. If the margins are close or positive, then radiation might be considered, because Merkel cell carcinoma has been known to recur not only distantly, but locally. And I think Dr. Thomas is going to give us a little update on radiation in Merkel cell, so I won't steal her thunder. And then the sentinel node biopsy is performed. And again, what that tries to do is really separate people who are low risk and node negative from much more high risk or node positive. And again, if the sentinel node is positive, we bring you back from additional consultation with our multidisciplinary group. And occasionally we'll do radiation to the nodal basin. That's probably the most common thing we'll do. But sometimes we'll do a node dissection. And then if you're sentinel node negative, you're probably just going to get observed. Next slide. So this is just some pictures of what we call a sentinel lymph node biopsy. And the concept of a sentinel lymph node biopsy, you kind of guess by the first word sentinel, is that if you can identify the first node that drains a specific piece of skin, and so for this case, a lesion on the arm, then you can accurately predict the status of the whole nodal basin. So instead of having to take out all the lymph nodes from a particular patient's armpit or groin area or neck, we can use this minimally invasive technique. I typically use two identification techniques. One is a radioactive dye technetium, which the technicians in nuclear medicine will inject for us. The second is a blue dye, which we inject in the operating room. And you can see us harvesting a node from the groin area on the left, which will then send off for special testing. Next slide, please. Why is it important to get a sentinel lymph node biopsy? Why do it? Do sentinel node biopsies cure people? The answer is no. But again, if you look at the bottom there, if you're sentinel node positive, your 5-year survival might be only 50 to 60%. Whereas if you're sentinel node negative, it can be upwards of 60 to 80%. And again, for these people who are at very high risk for recurrence and a poor outcome from Merkel cell carcinoma, again, multidisciplinary consultation is key. Radiation is often used. And I think you'll hear from my colleague, Dr. Sossman, we now have medical therapies that we give patients like this in not only the metastatic setting, but sometimes even in the adjuvant setting. So next slide. I think that's all I have. We'll save questions again, I think, to the end of the 3 speakers for this this part. And